So, as we have our next speaker, Dr. Ritika Sachdev, set up, and Dr. Ritika is going to be speaking a little more in depth about epithelial imaging as well as biomechanics in the diagnosis of keratoconus. We'll still be taking questions for Dr. Rohit. Please, ma'am.
Hello, sir. What is the current status of AI in the imaging of keratoconus?
I think most of your indices have some or the other AI inbuilt in it. Um, Keratoconus being such a multifactorial disease, just putting an AI on it will never yield the results what you want. But if you add multiple, all those parameters, I felt that needs a huge big data for it. So eventually it will come, but at this point of time, it's at very, very early stage.
So, while we wait, Rohit, following up on that question, do you see maybe a scenario where, irrespective of the kind of topography machine anybody uses, we can input that data into a central kind of repository to be able to compare topography maps, either color coded or based on numerical data, so that any patient going anywhere will get some information about what happened in the past and what will happen in the future?
We worked on some risk scoring, and the progression is based on risk scoring. But like I said, the sensitivity is very poor at this point. Not poor, it's very average. So, but still, it will give you a some kind of a red flag or green flag on what he should be doing. And the second thing is unwanted calling somebody for 3 monthly pentacam or topography probably will be avoided. See, I see a lot of them being asked for coming for 2 months, 3 months. See, you decide on if AI has a prediction that this chance of progression is less, then you can call the person after a year. So the footfall to hospital can be reduced.
Thank you. So, we look forward to hearing from Dr. Ritika Sachdev. Ritika, all yours.
Thank you, Dr. Praveen, for this opportunity. I'd be talking about epithelial mapping and corneal biomechanics. My talk is fairly basic. It's for the clinician and how to use these two tools to understand more of the puzzle of keratoconus. These two tools add to the understanding of keratoconus beyond the tomography. Now, why do we need to go into biomechanics and epithelial mapping? Is simply because the keratoconus journey moves that way. We were earlier diagnosing keratoconus on the slit lamp, then we moved to diagnosing it earlier on the tomography. But the earliest change that comes in is the biomechanical change, and hence it is a good place to enter in the diagnosis of keratoconus to catch it early, to document progression, as well as to exclude these cases from refractive surgery. Now, this is one of the most famous quotes of biomechanics, that cornea is not a piece of plastic, by Dr. Cynthia Roberts. The cornea is a heterogeneous structure with viscoelastic properties. The elastic properties more akin to solid, coming from the collagen. The viscous properties more akin to liquid, coming from the ground substance. Now, why we talk so much about biomechanics is now that we have a commercial device to really monitor the biomechanics. The device we use is the Corvis ST. Corvis basically stands for corneal visualization with Shimplug technology. So you're using the images, which is 4,000 images that can be captured in a second. And because this air puff that is used to deform the cornea lasts for 31 milliseconds, we are going to have 140 images of the cornea. So you see, with an air puff, the cornea deforms. So you are applying a force on a surface and getting a contour response, that is a change in the shape of the cornea. This shape change is an indicator of the biomechanical strength of the cornea. Just to showcase a normal and a keratoconic cornea, you see here that a keratoconic cornea is weaker biomechanically, hence the magnitude of deformation is more. The other points to note is that the central area is going to deform more, and there is a greater difference between the central and the paracentral area, right? So this simple monitoring using a lot of images can be broken down into biomechanical indicators, which is what we will be doing. Now, these are actual real life examples from my patients. You see here that though the response is from normal to keratoconus, simply by viewing it on the video screen does not give you the real picture. Hence, we break it down into mathematical indicators. These are some of the mathematical indicators. And this is the contour response, the dynamic response of the cornea to force being applied on it. When the force is applied on the cornea, the first response is for the cornea to first aplanate, the surface becomes flat, and then the surface goes to the concavity mode, right? So these are the two phases. Obviously, it will go into a deeper concavity if it is biomechanically weaker. So these are the indices that we get. First is the deformation amplitude, which means that the displacement of the apex and the paracentral area 2 mm away from the apex will be much more. It will go down deeper if the cornea is weaker. Okay, so this is the deformation amplitude. Then we have the radius. The radius, because it is going to be more curved, the radius will be shorter, so the inverse of the radius will be larger, right? So a larger inverse of the radius will again be a weaker cornea. The third is the stiffness. Stiffness, like Dr. Rohit said, is a great indicator introduced by Dr. Cynthia Roberts' team. Whenever you have a weaker cornea, you will require less force to deform it, right? So I think this is a great example. Think of a basketball and a beach ball, right? This also helps you understand the confounding factors. So if a ball is thicker, you will need more force, right? So the stiffness will be more. And if you inflate it fully, for example, if you have a beach ball or a basketball that is fully inflated, it will deform less. So these are the two things, the thickness and the IOP, which will also be interplaying into these parameters. So now coming to the IOP, just like a beach ball which is fully inflated will deform less, similarly a cornea which is at a higher IOP will deform less with the force. So these are the indicators that you must keep in mind. So when you see the cornea map of the biomechanical indices, there is an IOP that also comes in, especially if you're looking at progression. So also try to look at the IOP and see if it is matched or it is confounding results further. Like I said, these mathematical indicators are combined to give you a screening report. So these are largely the three mathematical indicators that I told you about, combined with a thickness profile. It was seen that when the thickness profile was added and a composite index of the Corvus biomechanical index was made, the sensitivity and the specificity was higher. So this is the Vinsegura screening report, which comes on the dashboard of the Corvus ST. And you see that these indices give you a composite CBI, which is color coded. Anything close to 0 is good, anything close to 1 is bad. You also have the color coding, and 0.5 is taken as a relative cutoff. Now there are newer indices that are coming in. This was by Ahmed Elshik and group. This is the stress strain index, which has now been incorporated into the Corvus ST. This index is very important because it doesn't have as much confounding by the intraocular pressure. It basically gives you a curve. The closer, the more straight it is and closer it is to 1, it is a good value. But do note that the reference subjects here were about 50 years old. So practically you may not get a value of 1, you may get a little lesser in younger subjects, but less than 0.5 will be fishy. What is most important is that this can be used to assess the progression of keratoconus or the effect of cross-linking. So if the curve is shifting to the right, that means the cornea is getting softer. And if the curve is getting more vertical and shifting to the left, that means the cornea is getting stiffer. The great magic happens when you really combine tomography and the biomechanical indices, which is the combination of the pentacam and the Corvus ST. When both the machines speak to itself, so you have the bad D, which you already have with the pentacam, you have the CBI or the Corvus biomechanical index, which I told you about, and when you combine these two with some degree of AI, it comes to the tomographic biomechanical index, the cutoff for which is usually taken as 0.29, and this is one of the most sensitive and specific indices that has been shown. That if you see, this is a paper showing that it is the TBI which gives you a better sensitivity and specificity for detecting the fellow eye biomechanical weakness in patients who do have keratoconus. So if these three indices are, even if TBI is suspicious, take it with more sense of concern than if the CBI is suspicious. Just moving on to some case discussions. Now, this is a normal topography for most of us, and we would be happy to do a refractive surgery in this patient, right? The tomography gives you good results. There is the bad display seems to be quite normal, but if you look at the Corvus biomechanical index, it is completely in the red zone, right? So this has pointed out to a biomechanical weakening of this cornea. Let us look at the fellow eye of this patient. This is the fellow eye. So it is a frank keratoconus in the fellow eye. So it is only the biomechanics that has possibly detected an early keratoconus with a normal tomography, and such a patient should ideally never undergo a refractive procedure. This is just to show the two tomographies. So biomechanics is perhaps a missing link that does add to our understanding of keratoconus. Another relatively good-looking refractive display map, you see that the tomography is largely normal, and what's really great is that all the indices are also in the green zone. So I think it's a clear green signal to go ahead with the refractive surgery. However, the fellow eye of this patient has keratoconus. So though we have discovered newer frontiers with biomechanics, a lot still remains undiscovered, and there are missing links which will add to our understanding. One of the missing links, of course, is that this is measuring the central 3.5 mm in most cases, and to have multimodal biomechanics and, like Dr. Rohit said, collagen imaging and other modalities come in will add to the pieces of the puzzle. So biomechanics is a great tool, but the more you know that you don't know. Now, coming to the epithelial mask on the anterior surface, this is just to show a representative that the epithelium tries to regularize whatever is irregular. So in a normal surface, the epithelium will be regular. However, if you have a small stromal cone, the epithelium over the cone tends to become thinner so that the overall corneal surface looks normal. What does this show? This simply depicts that when you do a placido-based topography, the anterior surface will be masked. The cone on the anterior surface will be masked, because this is what you see on topography. However, when you do a tomography, the posterior elevation shows up. So do you always need a topographer or a plus tomography, or can you add the epithelial mapping to a simple topographer to know more, right? So a lot of general practitioners just have a topography, and if they use the OCT to simply look at the epithelium, they can unmask the topography which has been masked by the epithelium. I'll be showing you some examples of this. Now, most of, like Dr. Rohit pointed out, most of the OCTs now have integrated the epithelial thickness map, and simply by subtracting the epithelial thickness by the total thickness of the cornea, you get the stromal profile. So you are able to get the stromal irregularity unmasked. This is what the normal epithelium looks like. It is thicker in the inferior part because of the pressure of the lids, right? So this is what a normal epithelial map is like, and you should hold this as a reference. In keratoconus, this was actually by Dr. Dan Reinstein way back in the year 2000. They noticed that the epithelium over the cone is thinner, and there is a donut-shaped thickening around it. This is in stark contrast to the normal profile of the epithelium. So let us look at this case. This is a patient who has keratoconic cornea, and just look at the epithelium pattern. It is thin over the cone, and there is a surrounding thickening. So this is a pattern which you very commonly see in keratoconic corneas, and for the general ophthalmologist, if you do not have access to a tomography system, do combine your topography with an anterior segment OCT to get the epithelial masking out and a clearer picture of the corneal stroma. So all in all, these are again some cases. This is a patient of mine with keratoconus. You see that the epithelium is thin and all the indicators, the biomechanical indicators, are in the red zone. This is again another patient. The epithelial map you see so beautifully throws out as big a finding. But, however, do note that the epithelium pattern may not always be as consistent. But if you have a doubt in patients, you must look at the epithelium, sorry, like I showed you here, right? So they are all in all pieces of the puzzle which, when fit together, make you diagnose better and assess progression better by unmasking the epithelium and understanding the biomechanics better. So I think my final musings are keratoconus, I think, is something that is a deep interest of mine, simply because each keratoconus is a learning, not only about the disease, but about science and mathematics, about nature and life itself. Thank you for your